So the next topic that we have to discuss is cardiac surgery. What you need to realize is cardiac surgery is one of the most demanding field among surgeons, and other specialties require 3 or 4 years to become masters in, but cardiac surgery is the field that requires 7, 8 or even 10 years before you can confidently say that you're a master in cardiac surgery. So, starting off with the history of cardiac surgery. Cardiac surgery is not as old as other fields of surgery, because as you can imagine, we discussed in previous lectures general surgery and amputations, and they developed in very difficult circumstances. Cardiac surgery could not be done in those circumstances. It was impossible. So it developed later than the other specialties. So the first successful heart operation was done in 1896, and it was just a simple suture of a heart wound. And later on, for congenital defects, cardiac surgery was established further. First ductus arteriosus was closed in 1938. First coarctation of aorta done in 1944, and so on and so forth, and from there on it progressed. Ductus arteriosus, coarctation of aorta, these are both congenital anomalies. They will be discussed in the later lectures. Similarly, indirect revascularization of the heart was established in 1930. First cases of direct coronary artery surgery were done in 1960, 60 or 64, something around in that period. And first large series of coronary artery bypass graft patients was done in 1968. This was actually a study involving multiple patients. The difficulty that is faced in cardiac surgery is this, that the heart needs to be stopped to repair intracardiac lesions or to improve coronary surgery. It is very difficult to operate on a beaten heart because of two reasons. First thing, simply just consider something. If you're trying to stitch something and it's continuously moving, it will be difficult for you to get a proper suture. And the second thing, myocardium is a very hard tissue. It's not easy to suture myocardium, it's not easy to operate on it, so we need to stop it to perform a good surgery. The stopping the heart, in other words, means a cardiac arrest. But the problem is, an irreversible brain damage will occur within minutes of a cardiac arrest. The brain tissue is very sensitive to hypoxia. So if you stop the heart and the blood supply to the brain stops, you will have irreversible brain damage within 3 minutes. So you cannot stop the heart for more than that under normal temperature conditions. So we have two solutions to this. First solution is you create hypothermia. This is a concept, there are two different concepts. There is a warm ischemia time and then there is a cold ischemia time. Warm ischemia time means that on normal temperature, how long can an organ remain devascularized before irreversible injury occurs. It is usually less than cold ischemia time. Cold ischemia time is how long you can keep an organ devascularized while you keep it cold. आप लोगों ने भी देखा होगा कि अक्सर जब ये ऑर्गन ट्रांसप्लांट या ये वो मूवीज़ वगैरह में देखा होगा, जब ये होता है तो वो उस ऑर्गन को आइस पैक्स के अंदर रखते हैं. मकसद ये है, if we lower the temperature, the ischemia time increases. यानी कि you can keep an organ in a cold atmosphere for longer time before it becomes permanently damaged. The second solution is a heart-lung machine, in which you replace the function of the heart and the lung using a machine. इसको हम बाद में in detail we'll discuss it inshallah. This is the first attempt of hypothermic technique in which surface cooling was done. It was done in 1952, and closure than a fatal septal defect in a 5-year-old girl was done. You can imagine, in this tub, the tub was filled with ice cold water and the girl was immersed in it, and the heart surgery was done. Must have been very difficult, and the maximum duration of time that they had to operate was 5.5 minutes at 28 degrees centigrade. So we increased the ischemia time from 3 minutes to 5.5 minutes just by keeping the patient cold. So moving on to practical matters of cardiac surgery, how do we investigate a person to determine if he needs cardiac surgery or not, or if he is fit enough to undergo cardiac surgery or not? When we consider diagnostic workup, the first thing we obviously need is an ECG, electrocardiogram. ECG simply measures the electrical potential generated by the myocardial conduction system. It's the simple trace that we see so commonly, and a physician and cardiologist can read it very well. They can assess minor changes in the patterns and the QRS complexes, and assess on basis of those assessments they can tell what type of problem the patient is suffering from. Second very common investigation that is done is an echocardiography. Echocardiography is basically an ultrasound of the heart. Ultrasound of the heart will show you the walls, the chambers of the heart. For example, in this diagram you can see this, because ultrasound probe emits rays, so it's usually in the form of a triangle. Okay, so if you just look at this diagram, this is the right atrium, the left atrium, the right ventricle, and the left ventricle. This will give you a very good image of the heart walls of the heart, and similarly the valves present inside this is the mitral and the tricuspid valve. This is good to know the anatomy of the heart, and also when the heart contracts you can see if all the walls are moving and contracting normally. If one of the walls is not moving properly during contractions, you can easily guess that that wall may be ischemic or damaged or something like that. The second advantage of an echocardiography is you can perform a Doppler. You can use it to assess blood flow. Different colors, as you can see in this second diagram, different colors will show blood flow in different directions and different velocities. So just by looking at a Doppler you can assess if the cardiac flow is in the proper direction, or if there is any regurgitation through the valves, and what's the velocity. You can assess the cardiac output using this technique. Then another commonly performed test is the exercise tolerance test. Exercise tolerance test is a modification of a simple ECG that we do. Simple ECG is like you just walk into a clinic and you ask the physician there, "Ji, I am having a problem. Why don't you do an ECG?" Aap letenge and you will get an ECG done. But that will assess your baseline function. But the patients with angina, अगर किसी angina patient को देखा तो आप लोगों को पता होगा कि वो थोड़ा सा जब चलते हैं या कोई फिजिकल एक्टिविटी करते हैं या जब कोई इमोशनल स्ट्रेस आता है या जब खाना खाया होता है, इवन उसके बाद पेन शुरू हो जाती है. दैट मीन्स द हार्ट इज़ वर्किंग optimally to provide your basic needs, but it cannot provide for the increased needs during the periods of physiological stress. So what do? We just put the patient on a treadmill and we take a continuous ECG trace while the patient works out. So this will give you an assessment of how the heart changes, how the heart conduction changes when the heart is under stress. Okay. Next is a thallium scan. Now this is a very sophisticated and very specialized test. Isme we inject a radioactive isotope into the patient, and we use a special gamma camera to image the heart. For example, if you see the diagram, if you get a picture like this, the red areas are well vascularized areas, the blue areas are the less vascularized areas. So if you see, it should be a complete, the red should be a complete circle because it shows a complete chamber, but there's a lacking area on one side, which means that part of the heart is ischemic. Then if you move on to further sophisticated investigations, we have an angiography. Angiography is अभी तक हमने जितनी इन्वेस्टिगेशन इससे पहले पढ़ी, दे ऑल डायग्नोस्टिक. एंजियोग्राफी का हमें ये फ़ायदा है कि दिस इज़ डायग्नोस्टिक, एंड इफ़ वी फाइंड अ प्रॉब्लम वी कैन ऑल्सो मैनेज दैट प्रॉब्लम. मतलब ये कि ये डायग्नोस्टिक भी है एंड एट सम पॉइंट्स इट मे बी थेराप्यूटिक एज वेल. एंजियोग्राफी में करते क्या है, एनआईवी कैनुला इज इंसर्टेड थ्रू अ मेजर वेन. क्यूबिटल फॉसा में से कर सकते हैं, रेडियल आर्टरी में से कर सकते हैं, वेन्स क्यूप्टल आर्टरी, क्यूप्टल फॉसा में से या वेन में से या फेमरल वेन में से, एंड यू जस्ट मिल्क दैट कैनुला डायरेक्टली अप टू द हार्ट थ्रू द वेना केवा, थ्रू अप टू द हार्ट। वहाँ जाके आप एक डाई इंजेक्ट करते हैं एंड यू टेक एक्सरेज, यू टेक फिल्म्स ऑफ दैट आफ्टर इंजेक्टिंग द डाई. If you see in the diagram above, this is showing the vasculature of the heart in a very nice manner. आप सबसे ऊपर देखें, that is the point जहाँ से डाई इंजेक्ट होके अंदर आई है, और उसके बाद these are the branches of the heart. अगर ये पूरा देखें तो this is the apex and this is the base of the heart. ये पूरा हार्ट और उसकी ब्लड सप्लाई आउटलाइन हो जाती है. तो इसमें यू कैन ईजिली असेस के हार्ट की ब्लड सप्लाई ठीक है, उसकी आर्टरीज, उसकी वेसल सारी अपनी सही जगह पे ब्लड सप्लाई दे रही हैं. अगर फॉर एग्जांपल आपको ये जो नीचे वाली डायग्राम में एक रेड सर्कल नज़र आ रहा है, अगर कोई इस तरह की चीज़ आपको नज़र आती है, इसको अगर आप ध्यान से देखें तो उस वेसल के अंदर एक छोटा सा गैप है, दैट इज़ द एरिया ऑफ नैरोइंग. ठीक, that narrowing may be due to any cause, usually it's atherosclerosis. So if you find something like this on the angiography, you can pass a balloon catheter. आप इसके अंदर से एक balloon catheter गुजारें, उस balloon को जब आप dilate करेंगे तो वो इस narrow portion को dilate कर देगा. In that way you will have a properly revascularized vessel. अगर आप इसी की second को देखें, उसमें you can see this area which was previously narrow, it has been dilated. Furthermore, इसी एंजियोग्राफी को आप यूज़ कर सकते हैं टू प्लेस a stent in a narrow vessel. If we put in a stent, now we call it angioplasty. ये तो हो गई diagnostic investigations which we use to assess if the patient needs a cardiac surgery or not. ठीक है. Next we have some hematological investigations. They help in diagnosis and also they help in assessing for the fitness of anesthesia. इसमें सबसे कॉमनली सबसे पहले इन्वेस्टिगेशन इज़ कंप्लीट ब्लड काउंट, जिसमें हमने हीमोग्लोबिन और प्लेटलेट काउंट देखना होता है. फिर वी गेट अ फास्टिंग लिपिड प्रोफाइल लेवल्स डन, देन रीनल फंक्शंस, लिवर फंक्शन टेस्ट, एंड ऑल्सो ऑफ कोर्स एक्सरे चेस्ट. All of these investigations will tell you if the patient needs a cardiac surgery or not and if the patient is fit to undergo cardiac surgery or not. अब अगर हम डॉक्यूमेंटेड इंडिकेशंस की बात करें, किन किन कंडीशंस में कार्डियक सर्जरी का फ़ायदा होगा, तो खैर इन इंडिकेशंस को वी हैव डिवाइडेड इनटू 3 कैटेगरीज. फर्स्ट कैटेगरी इज emergency indications of cardiac surgery in which we have to perform surgery on the same day. इसमें acute atrial regurgitation with early closure of the mitral valve, rupture of a sinus, valsalva aneurysm into right heart chamber, or rupture into the pericardium. All of these, if not treated, may cause sudden death. ठीक है, इसलिए if we find any of these, we have to operate on the same day. Next are urgent indications in which we have to operate it within a few days. If the valves are closed, if the prosthesis, that prosthesis is something we've put in ourselves that is unstable, it's not properly placed. If there is acute atrial regurgitation or mitral regurgitation leading to heart failure, or if there is evidence of annular or aortic abscess, sinus or aortic true or false aneurysms, fistula formations, or new onset conduction disturbances. If there is a septal perforation which wasn't there before, if there is a major embolism plus mobile vegetations greater than 10 mm, which have failed to respond to appropriate antibiotics. Okay, if you go on, this is mostly just cramming that you'll have to do. What we need to understand is most of these conditions will not immediately lead to death, but if they are left unchecked, if they are left untreated, they will gradually deteriorate, they will gradually increase the problems, and the patient will suffer. Well, then there are some elective indications. You may delay the surgery but not for too long. Staphylococcal prosthetic valve infective endocarditis, this may be treated with antibiotics, but if it fails to respond to antibiotics, then we have to operate, we have to change the valve. Early prosthetic valve infective endocarditis within 2 months after surgery, or if there is evidence of progressive paravalvular prosthetic leak, you put on a valve and now it started leaking, or if there is evidence of valve dysfunction and persistent infection after 7 to 10 days of appropriate antibiotic treatment, as indicated by the presence of systemic signs, and then we need to operate. Fungal infective endocarditis caused by a mold or by a yeast. Fungal infections usually do not respond to antibiotics. So if we find a fungal infection and it's not responding to any of our treatments, it's not going away by itself, then we might have to operate. Infections with other difficult to treat organisms, any other organism which fails to respond, and vegetation growing larger during antibiotic treatment. Cardiac surgery has been a difficult surgery from the very beginning, but in the recent years, some advancements have actually made life easier for cardiac surgeons. Some of these innovations include mechanical ventilation, because patients undergoing cardiac surgery undergo a major physiological stress. It's not easy for a person to come out of cardiac surgery, and because whenever we are performing cardiac surgery, obviously the lungs are also compromised during surgery, so post-operative recovery for these patients is very difficult. And if we can just place the patient on mechanical ventilation for the first 1 to 2 days, it helps the patient recover in a much better way. Defibrillators are those machines which give an electrical impulse to a stopped heart and restart it. These defibrillators are really good because, as I told you in pericardiocentesis, even if we touch the myocardium with a needle, it may lead to arrhythmias. Now we are operating on the heart. What do you think it will do? It will, in many cases, cause a heart block. Heart will suddenly switch off. So we need to switch it back on. We do that using a defibrillator. Even cardiac surgeons, I have a friend in FSC who once told me they have small electrodes, handheld electrodes, like they just place it directly on the heart and give it a small shock to switch it back on. Then transfusions. Blood transfusions has always been associated with many risk factors, but with the latest advances in screening and testing and all that, transfusion will become safer. Heparin is a wonder drug for cardiac surgeons. Heparin will prevent many thromboembolic problems that they may face. Advancement in antibiotics. We have most advanced and widely active these antibiotics which are effective against multiple organisms. Cardioplegia, we can actually slow down the heart now using drugs, or we can slow down the heart by reducing its temperature, and that has effectively helped us perform beating heart surgeries as well. Or selective coronary angiography, we can do an angiography directed especially at the cardiac vessels. So how do we open up the chest? How do we get to the heart? There are 3 main methods. Either we perform a sternotomy, जिसमें हम sternum को खोलेंगे, sternum को काट के खोलेंगे chest को mid से. Second one is a thoracotomy, जिसमें हम thorax को chest wall को laterally anteriorly खोलेंगे. And the third one is the minimally invasive cardiac surgery. In sternotomy, the sternum is using a hand drill or a saw. The sternum is cut in the midline. ऊपर से नीचे तक midline में हम sternum को काट के खोल देते हैं, and we use a retractor to just open it up. This will provide you the best access क्योंकि directly the heart will be in front of you, और पूरे heart का interior wall जो है वो सारी की सारी आपके सामने exposed होगी. इससे आप almost सारे के सारे cardiac procedures कर सकते हैं. Self-retaining retractor is placed in the chest wall, and you just open up the chest. इसके बाद you open the pericardium and you stitch it to the wound towel, so that will help pull up the heart. आपने pericardium को अगर आप as an envelope consider करें, आप उस envelope की interior wall को काट के खोल रहे हैं और आप उसको खोल के ऊपर किसी चीज़ के साथ बांध दें ताकि वो नीचे से भी उसको ऊपर को खींच ले. बहुत अच्छा, बहुत proper exposure मिलता है. You can perform almost all the surgeries with this technique, but the problem is it causes post-operative pain. Whenever you try to expand the chest, there's either fracture of the ribs or stretch of the muscles. Sternum तो आपने basically काट के खोली है, so it will cause a lot of pain in post-operative period. This is usually closed using stainless steel wires, and we put in chest drains. दोनों साइडों पे चेस्ट में एक चेस्ट ट्यूब डलती है, राइट और लेफ्ट में, and the third drain is placed in the pericardial cavity. ठीक है, if the output becomes too much in any of these drains, you might have to re-explore. Then these incisions have already been discussed in thoracic surgery. This is right anterolateral thoracotomy. The incision is extending from the anterior side of the chest onto the lateral aspect. Again, you put in drains, and there's left posterolateral thoracotomy. Isme you can either approach the heart from the right side or from the left side, depending upon whatever the indication is. Isme, if you see, you've given an incision along the scapula and down on the chest. This is posterolateral. Then there's another incision which may be used. This is a thoraco-abdominal incision. You extend the incision from the chest onto the abdominal wall. This whole flap will be lifted and the heart will be directly in front of you. This is a clamshell Ancien or bilateral transverse thoracosternotomy, in which the incision is made on both sides of the chest. Basically, you're just lifting the chest wall up and you're pulling the abdominal wall down, and you're looking through the diaphragm into the chest cavity. This will give you a good view to the inferior wall of the heart. Minimally invasive cardiac surgery is better than all of these. This uses smaller incisions and it reduces the trauma of access, preserves the integrity of the chest. It is more cosmetic. अगर आप में से किसी ने किसी bypass के patient को देखा हो, तो they have a big wound directly in the center of the chest and it looks really bad cosmetically. And इसका एक second advantage ये भी है, this avoids extracorporeal circulation. You don't need to put the patient on that machine. But minimally invasive cardiac surgery remained far behind other specialties because open cardiac surgery results इतने अच्छे थे कि nobody even thought about going for minimal invasive cardiac surgery. They thought that the results are so good, we don't need to improve them further. And there are many constraints of cardiac surgery: motion of the heart, limited duration of induced cardiac arrest, which basically gave this idea to the cardiac surgeons that we need to just open it up, do it quickly, and close it. Minimally, if you open a chest for a small incision, you won't have good exposure and it will take more time. That was the general concept. Minimally invasive cardiac surgery was progressively introduced owing to progress in cardiopulmonary bypass, intrathoracic cardiac visualization, and instrumentation. Gradually, it gained favor among the surgeons, but still some surgeons remain critical. From here on, we will be discussing complications of cardiac surgery in the next lecture, inshallah, and other cardiac procedures as well. Thank you.